I'm going to talk about biceps options in treating biceps tendon pathology. Again, my disclosures. Important to understand the anatomy, where it's intra-articular and extra-articular, and where there are involutions of both the falciform ligament and the subscapularis, which create the sheath over top. Intra-articular it originates in the supraglenoid tubercle. There's an intra-articular portion of about 35 millimeters, and the coracohumeral ligament really stabilizes the biceps tendon, not so much the sheath. Extra-articular begins at the transverse humeral ligament. Falciform ligament of the pec major tendon can be part of the bicipital sheath. Just to highlight what Brian said, it's important to understand the blood supply as a key to the pathology. This was an arterial supply of long head of the biceps tendon. 20 cadaveric tendons injected with dye, and they noted a zone of hypovascularity 1.2 to 3 centimeters from the tendon origin. Now, so there's a decrease in blood flow as the tendon enters the groove, and in addition, as Brian referenced, the anterior superior labrum and glenoid has an area that's devoid of blood supply at the anterior attachment of the biceps root, which is going to affect healing of both your SLAP lesions and affects the type of injury that you'll get. So the pathologies in general can be synovitis, tendinopathy, acute rupture, chronic rupture, biceps instability or pulley lesions, biceps degeneration with a rotator cuff tear, post-traumatic scarring as in a proximal humerus fracture, and an entity described as an hourglass biceps. For synovitis and tendinitis, usually presents with anterior shoulder pain at the biceps, exacerbated by overuse. Standard conservative management with physical therapy and a cortisone injection is warranted. If those fail, in my hands, I go down to the bone in the groove and then back up the needle and slowly inject. If I feel any resistance, probably means you're in the tendon and you need to reload. In terms of an acute rupture, and I see a lot of these because my office is in Burbank. We're surrounded by the studio, so we see a lot of grips and behind-the-scenes folks from the television and film industry. We have to talk about non-operative and operative treatment. Usually cosmesis is a concern in a young patient or a gym rat. Particularly in a laborer, there can be fatigue cramping. Supination strength diminishes about 15 to 20%, and in my laboring population, that is not generally tolerated. Flexion is generally not affected. Chronic rupture can give you early fatigue and cramping and the Popeye deformity. I've also had patients who complain not so much of the cramping, but a knot of tendon in the arm, and they just want the piece of tendon removed. There are also these lesions of the biceps pulley. Braun described 229 shoulders at arthroscopy with these pathologies, and he noted that 32% of patients had a pulley tear. The anterior medial and posterior lateral structures cause subluxation or dislocation of the biceps tendon, and also they were highly associated with SLAP tears. So here's the normal pulley with the biceps, the humeral head, and starred is the superior glenohumeral ligament. And here you can see there's erythema, and the ligament is down below. It's traumatized. And here's what it looks like on a video. You can see that there's been some damage to the structures surrounding the pulley, and this is now subluxed. This is a subtle finding, but you really need to look for it because it can affect both the area of the SLAP lesion and also the intertubercular portion of the biceps. This is the hourglass biceps, which is described. It has a fattening across the intra-articular portion, described by Boileau, entrapment of the long head of the biceps tendon. As a cause of pain, the incarceration of the tendon in the joint is seen with diagnostic arthroscopy, and treatment is tenotomy or tenodesis. It's fairly uncommon, I think. Diagnostic imaging for the long head of the biceps, really not very sensitive or specific. Your physical exam is really going to be the hallmark of your diagnosis. Let's talk about some different treatment options. Tenotomy. This is a study that was done by Gill back in 2001. 30 shoulders, arthroscopic biceps tendon release. Had a complication rate of 13%, but had a significant reduction in pain and improvement in function. So they seem to do well, but the complication rate is primarily Popeye deformity, which some patients did not tolerate. Here's a group addressing that issue on tenotomy. 80 patients, they graded anterior shoulder pain, muscle spasms, cosmetic deformity. no statistically significant difference between tenotomy and tenodesis on everything other than cosmetic outcome. 30% incidence, pretty high. But again, it's going to depend on your population. Here, Kelly's study in 2005 had isolated arthroscopic release. 70% of people had Popeye sign. That's 82% of men and 36% for women. There was no arm pain at rest, but almost 40% had some soreness with resisted elbow flexion. So that kind of goes against our understanding of what the mechanism of the biceps tendon is. Arthroscopic tenotomy of the long head of the biceps in association with rotator cuff tears. The full thickness tears were determined to be inoperable, or patients who did not want to do a long post-op rehab, generally an older population. This older group was relatively satisfied with their tenotomy. And then an overview in 2011, literature reviewed going back to 1966. Popeye sign was seen in 41%, and at cyclic loading, 40% failure in the tenotomy group, meaning that it migrated. Load to failure in the tenotomy group significantly different than in the tenodesis group. Now here's a technique where a biceps tenodesis is performed associated with the rotator cuff tear. They put a stay suture in the biceps tendon, and then they go ahead and mobilize the cuff laterally. So you can see on the picture on the right where they're incorporating the tendon. They go ahead and do a tenotomy of the tendon and incorporate it laterally. And you can see on the picture on the left how it's along the area of the greater tuberosity. I have a little bit of concern for this, since it seems like if you're externally rotating or forward elevating, you're going to present a different vector for the biceps, but they reported that their results were pretty good. So 15 patients, 32 months, a low group. One patient did actually disrupt the tendon and had a biceps tendon disruption, but no patients had pain at the intertubercular groove, and they had excellent improvement in range of motion. So what about soft tissue or bony fixation if you're going to do a tenodesis? Here's a study by Schneibel, 67 patients, sort of half and half, constant score, and they developed a long head of the biceps score, and they evaluated by MRI the location in the intertubercular groove, or whether it was distal, that they counted as a complete failure. They said bony fixation showed significant improvement with the long head of the biceps score, 91 versus 80. Again, cosmetic seemed much better in the tenodesis group. So they deducted that bony fixation offers significant advantage for clinical and structural outcome. Well, here's a group of open subpec tenodesis with an interference groove versus suture anchor fixation. Is the suture anchor adequate? They used a VAS and a modified constant in shoulder, and they had some failures, but they said that there was no statistical difference in those two groups. Now, this is cyclic testing of 5 methods of fixation in a porcine model. Their deduction was that interference screw fixation was superior biomechanically relative to these other techniques. So here's a comparison of screw length and diameter that came out of Chicago, 42 cadaveric shoulders. Does it make any difference in the size? Does size matter? Arthroscopic proximal, these different biotenodesis screws, preloaded and cycled 300 times and loaded to failure, and they measured those parameters, and they found that there was no difference. So therefore, it was recommended to use the smallest screw size available to minimize the risk of stress fracture in the tenodesis site. Now, the question is, where to tenodese? Is there a higher tenodesis result in post-op pain if you move an arthroscopic tenodesis distal, suprapectoral? 17 patients with an arthroscopic tenodesis, 5 in the upper half of the groove and 12 in the lower. 2 of 12 had persistent pain at 15 months, and those were both in the upper half. A small study, but food for thought. And these cadaveric specimens were looked for optimal placement for safe surgical technique. And they determined that minimally invasive proximal tenodesis should be 1 to 2 finger breadths below the lesser tuberosity to maintain adequate tension length. It's not without complications. Here's proximal humerus fracture after keyhole biceps tenodesis. But overall, Here's a review of arthroscopic tenodesis, again out of Chicago. They open the groove with the electrocautery, skewer the biceps tendon with a spinal needle, and tag it with a suture. Biceps tendon is delivered from the groove, and they go 1 centimeter distal to the most proximal groove, drill an 8 millimeter socket over a guide wire, and in this study used a 9 by 25 millimeter interference screw. The arm is at 45 to 90 degrees of flexion, and you can assess tension with a probe. Now, this is an overall complications with a large group of patients, only 7 complications with this subpectoral tenodesis. 1 deep infection, 1 patient got RSD, but a very low incidence. So for open biceps tenodesis, excellent. And in this study, tenotomy versus tenodesis for pathologic lesions of the tendon, they looked at a comprehensive literature review and said that to date, the literature does not provide evidence to support one technique over the other, and there are advantages to each procedure. So the author's preferred method was tenodesis with interference screw. In my hands, I don't see an advantage to one or the other. If cosmesis is important, then obviously tenodesis is the route to go. If you have a laborer who needs to maintain as much strength as possible in supination, then you're going to favor the tenodesis. If you have an older patient who doesn't want to go through an elaborate rehab, you do a quick scope, tenolyse it. Usually that's an age over 65, or a low demand person. I always do a tenotomy and a total shoulder or hemiarthroplasty. Tenodesis does require immobilization, so there is rehab. I do those in generally younger patients, and given my age, that's anybody under 65, and certainly a laborer. Thanks very much.